Hello students, today we are going to focus on gas exchange and the disease process of COPD. Attached are the student learning outcomes for this disease process. So please take a moment and pause your screen and review the student learning outcomes. You should have reviewed oxygenation in fundamentals to nursing, but let's go over it so we can see how it corresponds with the disease process of COPD. So gas exchange is the process by which oxygen is transported into the cells and carbon dioxide is released. Alveoli are the very small sacs where the gas exchange between oxygen and carbon dioxide takes place. Oxygenation is considered the process of obtaining oxygen from the atmosphere and making it available to your organs in your body. Your body needs oxygen to maintain adequate perfusion. And if there's a disease process that interferes with this oxygenation process, then your body isn't getting perfused well. Right? Adventitious lung sounds. Lung sounds are auscultated along the larger airway. We listen to bronchi, bronchial. Also, we listen to alveoli area, right? Vesicular, bronchovesicular, and bronchial sounds. Crackles usually means that the patient has some type of fluid in their lungs or in their alveoli. Wheezing, we usually associate that with narrowing of the airway space or narrowing of the bronchioles. Bronchi are heard during exhalation. That's when you breathe out. And a lot of times can be relieved by coughing. Bronchi a lot of times means like an obstruction or your lungs are filled with fluid and mucus and other secretions. So take a second to define the terms and associate yourself with what conditions that you can hear these sounds. Also take a moment to review Harding pages 540 to 545 for oxygenation therapy and oxygen delivery systems. So you know the level of oxygen a patient should need and when you should accelerate to a new oxygen delivery system, right? Remember that oxygen is considered a drug. Through autonomy, nurses can only administer 2 liters nasal cannula in an emergency situation to stabilize the patient. Anything more than 2 liters, they need to get a doctor's order and consult the doctor. Anytime you apply oxygen, you want to assess and reassess the SpO2 or PaO2 as needed. Monitor for manifestations of O2 toxicity and know the order of increase of oxygen delivery systems. And that's very important because if you're maxed out on a nasal cannula at 6 liters and your patient is deoxygenating, let's say around 88, 89, or even lower percent of SpO2, you need to know what delivery system you're going to go to next, whether it be a simple face mask or a Venturi mask or a high flow nasal cannula or a non-rebreather. You also need to know the purpose of these oxygen delivery systems. What's the purpose of a non-rebreather, right? At some point your patient might be retaining CO2 or they're not retaining CO2, so please make sure you know the reason for each delivery system and why we would use them in practice, especially now that you're being introduced into an acute care setting. After you review oxygenation as a concept, we can now move on to COPD. COPD is considered chronic obstructive pulmonary disease. Chronic meaning it is a progressive lung disease characterized by a persistent airflow limitation. It is also a chronic inflammatory response in the airways and lungs. What does this mean in aspects of a patient? This patient has had limited airflow, meaning they have been deoxygenated over time. A lot of times people with other disease processes such as asthma, they can end up with COPD. Or people who have had chronic lung infections, sometimes they can end up with COPD due to that chronic inflammatory response of the lungs. So we consider this a progressive disease. It gets worse over time, and a lot of times it is irreversible. So the walls of alveoli are destroyed, forming fewer alveoli, and they begin to become out of shape. Bronchioles lose their shape as well and become clogged with mucus. So if COPD is a chronic inflammatory disease process, how can we identify risk factors that can decrease the risk of your patient developing COPD? So, of course, cigarette smoking. You would want to tell your patient to decrease or completely stop cigarette smoking. Smoking cessation will help with that because as a patient stops smoking, their cilia in their lungs begin to heal themselves. All right. People who have occupational jobs such as chemical plants or places where they inhale a lot of dust, they are at a higher risk of developing COPD. Right? So a lot of times when that comes into play, lung irritants like chemical fumes and such, we tell the patient it is important to definitely wear the proper PPE for the job that they have, or maybe it is time for this patient to change jobs. Infection. Chronic infection can damage your lungs over time. All right, we're talking about people who get a lot of upper respiratory infections or lower tract respiratory infections. So like pneumonia, bronchitis. A lot of times these people have some type of other underlying issue going on, such as cigarette smoking, which increases your risk of lung infection, or asthma. Asthma is an obstructive airway disease process. So it also kind of obstructs the airway, but it's due to inflammatory issues such as allergies, right? That brings in air pollution. Some people who live in areas, especially like, let's say, Baltimore City. Baltimore City has a high pollution rate in the air, especially, let's say, back in the 80s, we were known as an industrial city. But just think about now, such as days when there are cold reds and cold yellows, right? Or the air pollution is thick. Or even last year when we had the smog coming from Canada and the wildfires, and you look at the news and they say today's a cold red day, today's a cold yellow day, right? These increase the risk of people who already have other obstructive airway problems going on, and it can add to, number one, their chronic inflammation, especially asthmatics. So sometimes we'll recommend like, hey, today might not be a good day for you to go outside. All right, today might be a day where you need to take more of your medications to help you with breathing. Aging. As you age, you lose more elasticity in the lungs. In genetics, there is a familial aspect linked to people who have COPD. It's a certain gene that we'll go over in the next slide. So what is alpha-1 antitrypsin? Alpha-1 antitrypsin is a protein that protects the lungs from damage caused by neutrophil elastase, an enzyme released by white blood cells to fight off infection. So if your patient has an alpha anti-1 trypsin deficiency, they do not have that protective measure in the lungs, right? This can be the genetic aspect that we talk about when we say that it has a familial history and genetic component of COPD. So this measures the level of alpha-1 the test measures the level of alpha-1 antitrypsin in the blood. So for diagnostic purposes, if we want to see, hey, my patient has COPD, their mother had COPD, and their grandfather also had COPD, let's see if there's a genetic component. We'll test that patient for the level of alpha anti-1 trypsin in the blood to see if they have a deficiency and that they are unable to protect their lungs from chronic damage. So, what cues do you look for as a nurse for a patient who has COPD? Right? Again, COPD is characterized as chronic airflow limitation. And we haven't gotten to that point yet, but it can be broken down into two different parts. A patient can have the emphysema component or the chronic bronchitis component of COPD. But in general, someone with COPD can be easily fatigued. They may present with frequent respiratory infections. Breathing, they might have dyspnea, pierced lip breathing. They might present with a barrel chest. You might hear wheezing, auditory or listening with your stethoscope. They may use their accessory muscles as breathing. They could be orthopenic. Orthopenic means standing. They're having trouble breathing while standing, or they prefer breathing while standing. They could be thin in appearance. Digital clubbing, what is that? That is clubbing of the digits, right? That shows chronic deoxygenation in the capillaries. This patient can also have a chronic cough, whether it produces phlegm or not, right? And sometimes we say mucus. They can have increased mucus, or they could just have increased cough without mucus. Productive versus non-productive. Right? A lot of times the increased sputum comes along with patients who have bronchitis. This patient can also present with cor pulmonale. We consider this a complication of the later in the disease process. So someone who has had COPD for a long time, they may present with what we consider cor pulmonale. And that is when they start having heart symptoms, right, or heart failure symptoms due to COPD. In a nutshell, and this is from Harding, the patients can present again with barrel chest, and that is the image you'll see, right? When we consider barrel chest, the chest is more bellowed out. Hypoxia, chronic intermittent cough, chest heaviness, increased work of breathing, air hunger. Air hunger looks like someone who is fighting to breathe. They can have progressive dyspnea, and it may be on exertion, and it may become more severe when they try to complete ADLs. This patient may present with fatigue, weight loss, and anorexia. Well, why does this patient have weight loss and anorexia? Just think of it this way. Their COPD is so exaggerated, or exacerbation is so, their exacerbation is so bad that at times they have to decide whether they want to eat or if they want to breathe, right? This patient can progressive dyspnea even while they're eating. They may present in a tripod position. Tripod position is another way to resolve orthopenia, and this patient will probably naturally present in this position just because it's easier for them to catch their breath. Pursed lip breathing on exertion. All right, this is just again another way that people with COPD present, and this is something that we recommend because it helps them blow off the CO2. But a lot of times they do it naturally, and you'll see that as a cue within your patient. So we break COPD down into two aspects of the disease process: emphysema and chronic bronchitis. In emphysema, we consider it to be for alveoli, The alveoli is constantly being damaged, and it is a constant inflammatory process in which the alveoli becomes damaged and air begins to be trapped. Right, we consider it air trapping, and that's why a lot of people with emphysema present as barrel-chested. Their alveoli ducts and alveoli, they lose elasticity, right? That's that loss of elastic recoil. So it's unable to push the air in and out of the alveoli space. In chronic bronchitis, right, this happens more in the larger airway spaces like the trachea and the bronchi, right? Chronic inflammation of the bronchioles, as well as airway obstruction and increased mucus production. Chronic bronchitis, right, is a clinical diagnosis of someone who has a daily increased productive cough for 3 months or more in at least 2 consecutive years, right? So a lot of times we consider this person a blue bloater. It's a good way to think of it. They're blue due to decreased oxygen levels. We consider them bloated due to abdominal bloating. This patient usually presents as overweight or obese, and their skin and their lips always have like a bluish tint due to cyanosis. Their cough is usually more prevalent than emphysema. You can hear more rhonchi and wheezing in this patient due to the bronchial constriction. And they often have more like of a cyanosis appearance and peripheral edema. So with emphysema, patients present with barrel chest. They're skinnier. They have fatigue. We consider them to be CO2 retainers. Right? So they have reddened skin due to chronic hyperventilation. And we consider them to be a pink puffer. Right? They have severe dyspnea. They often present with pierced lip breathing. On a chest x-ray, you'll see that their chest is hyperinflated with a flat diaphragm. Right? That's because of the barrelness, right? The chronic retaining of the CO2 and the chronic struggle for air. All right. The pathophysiology diagnosis of emphysema is permanent enlargement and destruction of air spaces distal to the terminal bronchiole. So this disease is happening again in the alveoli. And one thing we always say about emphysema is this patient has lost the elastin that they need in their lungs. Right? So breathing for them is harder. They have lost the elastic recoil in the alveoli sac and those smaller bronchioles near the alveoli. So how do we diagnose COPD? Well, often with most diseases, of course, we get a health and physical. So we will collect certain data from the patient. We'll look at their cues, right? Certain things like dyspnea on exertion, right? The way they breathe and how they're presenting to us. Diagnostic wise, we'll get a chest x-ray, right? With the chest x-ray, we can see certain things like hyperventilation of the lungs, hyperinflation of the lungs, right? That flattened diaphragm effect from the hyperventilation. We might use the spirometry. The spirometer is the most common type of pulmonary function test. Right? This measures how much air you can breathe in and out of your lungs, as well as how easily and how fast you can blow the air in and out of your lungs. So think of a balloon. How quickly that balloon can inflate right? How quickly and at what force that balloon can deflate. We're going to look at ABGs, right? So if your patient is a CO2 retainer, that's what we consider COPD to be. The patient is holding on to COPD within the body. COPD makes the body what? Acidic. So this patient will have respiratory acidosis. We'll have a 6-minute walking test, right? It's a simple test that measures the function and exercise in people with COPD, right? How well do the heart and the lungs respond to light exercise with a patient with COPD, right? Did the patient need oxygen within the 6-minute walking test? Did the patient drop below a certain SpO2 during the 6-minute walking test? And again, we'll also get the serum anti-1, antitrypsin level. I'm sorry, a serum A1 antitrypsin level. Right? That's how we measure that genetic component of the COPD for the patient. There's a little information about a spirometer, and as you see, they will clamp the patient's nose so air cannot get in and out of the nose. Right? It confirms the diagnosis in those suspected to have COPD, so it measures how well the lungs are inflating and deflating and at what force. It confirms the presence of airflow obstruction and determines the severity of the COPD, so what level of COPD is this patient at. So, nursing goals. Number 1, you have identified what COPD is. You have identified that your patient has COPD. The patient has been diagnosed with COPD. Now, what are you doing to help this patient as the nurse? Right. Number 1, you want to help improve their respiratory function. This is a respiratory disease. Think about it that way. Right? You want to help them improve their activity tolerance. Right? Whether it is chronic bronchitis or emphysema, you want to help improve their nutritional status, right? Whether the goal is them to lose weight or if the goal is for them to gain weight in muscle and protein, right? You need to have effective coping with this chronic disease, right? This disease isn't going anywhere. So it can have a psychological aspect on the patient. And so we come in with the effective communication. And you want to prevent the progression of the disease, right? So this is a chronic progressive disease, but this is stating that you want to help the patient slow down the trauma to the lungs or slow down the disease process as much as possible. Right? So now we're at the take action phase of the process, right? What are you going to do as the nurse? What is your management of this patient? Right? If we identify the risk factor of smoking, you want your patient to stop smoking. So smoking cessation will directly help slow down the progression of COPD. Certain drug therapies will go over the pharmacological aspect of COPD in further slides. You want to teach your patient airway clearance and deep breathing exercises, right? This patient, when we say airway clearance techniques in the huff cough, this is when we start talking about how to clear the airway of that mucus, right? This patient is, especially the chronic bronchitis, they have a lot of mucus in their airway. Breathing exercises and retraining. This is when the pierced lip breathing comes into play, right? You're teaching your patient to breathe in through their nose and blow out through their mouth slowly. This helps get some of that CO2 out of the body. Right? As long as there is no contraindication, maybe when we say contraindication, we're talking about a patient with heart failure. They need to be hydrated at least 2 to 3 liters a day. This patient is at high risk for infection and viruses, and especially viruses that affect the lungs, such as influenza and pneumonia. So if you want to teach this patient that it is vital for them and their health that they stay vaccinated. Some of these patients are on home oxygen. or long-term oxygen. So this brings into play other management and things we do to manage people at home on oxygenation. So make sure you look that up as a fundamentals review, right? And that brings into play like changing the nasal cannula out. How often does the patient need to do that? Right? Safety concerns about having oxygen at home, right? If this patient is on oxygen at home, they cannot smoke cigarettes in the house. It is a fire hazard. Progressive exercise plan, especially walking and upper body strengthening, right? That upper body range of motion. If this patient is DOE, dyspnea on exertion, right? They're unable to exercise. They have to keep some type of form of mobility about them, right? And this is when we will consult whole physical therapy. There are also other things such as pulmonary rehab. And pulmonary rehab helps people who have lung damage or lung problems retrain their body and their lungs. And pulmonary rehab can teach them certain tricks and stuff about how to get their ADLs done, right? How to group their day where it's so like they're oxygenated throughout the day, but still able to get their activities done. So this is something you can recommend for your patient with COPD. So teaching wise, you want to teach your patient breathing exercises and positions that will provide relief in instances of shortness of breath, right? One thing we talked about earlier was the tripod position. A tripod position can be standing or sitting. Basically what it is the patient is bent over in efforts to catch their breath in a sense. Another thing is sitting upright, seated in a chair, right? Some patients don't even like to lay flat in the bed. They find better relief sitting upright in their seats. Sometimes they can do a tripod wall position where they have both feet planted and they're leaning over to the wall, or a reverse seated position. All of this just ensures that your patient is at a level where they feel like it's best for them to catch their breath. And then it helps relieve them with shortness of breath. It also makes them stationary, so that way they're not having an exertion on activity that probably also contributed to the shortness of breath. During sitting in some of these positions, they can try other breathing techniques as well while they are planted. For instance, like the pierced lip breathing that we talked about. Pierced lip breathing. You tell your patient to breathe in through their nose for 2 seconds or 2 counts, and then breathe out for 4 seconds, right? This allows a longer expiratory phase, right? When you breathe in oxygen. When you breathe out CO2. So that way the patient is breathing out twice as much carbon dioxide than they are intaking oxygen, right? Orthopedic position in general, it is used to decrease the work of breathing by allowing greater chest expansion, right? This way the patient is able to use those accessory muscles better. All right, and this is another orthopedic position with the patient in the bed using pillows, right? They're able to prop their arms up, again allowing greater chest expansion. So with drug therapy in the chronic obstructive pulmonary disease, it is with a stepwise approach, right? We'll use the lowest step to achieve the optimal control based on the severity of COPD. Right? For mild or moderate symptoms, we usually like to start our patient off with a SABA or a SAMA. SABA stands for a short-acting beta agonist, or SAMA, which is a short-acting mesenteric agonist. Right? We consider this monotherapy, so it's either one or the other. Right? We consider short-acting drugs a lot of times as rescue inhalers, and this is just for symptom relief. Sometimes you can also do a SABA and a SAMA with combination therapy. That's the next step. as the patient progresses. For symptom relief and prevention of exacerbations, this is step 2. So what do we mean by this? This is for someone who might have an acute problem as well as trying to prevent further exacerbations. When we mean exacerbations, we mean that they're at the stage in the disease process where let's say they keep getting sick, right? They're not maintaining, they just keep having problem after problem after problem. So we'll give this patient a LABA, which is a long-acting beta agonist, or a LAMA, which is a long-acting muscarinic agonist. Again, that's one or the other. A LAMA and a SAMA should never be used concurrently. But you can use a SABA and a LABA. So those are the beta agonists, right? Those bronchodilators. You can use a short-acting bronchodilator with a long-acting bronchodilator, but you cannot use a LAMA and a SAMA together. Another step up, you can use a LABA and a LAMA together in combination therapy. And then lastly, to prevent exacerbations, you can do a triple therapy, which is a LAMA, a LABA, and an ICS. ICS stands for intercorticosteroids, right? Those inhaled corticosteroids, excuse me. And we'll get more into these medications in the next slide. So those SABAs and LABAs, they're considered beta-2 adrenergic agonists, right? Again, a SABA stands for short-acting beta agonist. This is your albuterol. A lot of times, again, you'll hear this title as a rescue inhaler. It's coming to the rescue of the symptoms that the patient is currently having. They can also have a LABA, right? Those are those long-acting beta agonists. We consider that to be salbutamol. Most beta adrenergic agonists, also known as bronchodilators, NNTEROL. That's the suffix. These can be administered via nebulizer or inhaler. Side effects are tremors, restlessness, anxiety, tachycardia, arrhythmias, especially with patients with underlying cardiac diseases. So a lot of times with these bronchodilators, we'll put a cap on how often they should use this inhaler because it can cause tachycardia. Then your patient is starting to have anxiety along with the other symptoms of feeling short of breath. Inhaled corticosteroids. All right, we went over corticosteroids a few times already this semester. All right, it is an anti-inflammatory drug. The mechanism of action is it is used to decrease the inflammation throughout the lungs. All right, local side effects include oropharyngeal candiditis. What is that? Thrush, right? It is yeast of the mouth. That's what that picture is showing you, right? This is a real reason why we teach the patient that after using this inhaler, they need to gargle with water or mouthwash after each use. Right? Another local side effect is hoarseness or dry cough. Spacers can be used with this medication to increase the delivery. A spacer is something that you can attach to an inhaler to allow the patient more time to inhale the medication properly to ensure that it is reaching their lungs. All right. Alternate therapy, if inhaled corticosteroids probably isn't doing the trick, sometimes, of course, we can use oral corticosteroids or IV corticosteroids if the patient is in an exacerbation. All right. But again, with triple therapy, we would do a LABA, long-acting beta agonist, a LAMA, a long-acting muscarinic agonist, with an inhaled corticosteroid. So we'll do all three of those together. And that is someone who has severe COPD that we would initiate triple therapy using this inhaled corticosteroid. So short-acting muscarinic agonist, ASAMA, and a long-acting muscarinic agonist, ALAMA, falls under the drug class of anticholinergics, a drug class that you should already be familiar with. Anticholinergics produce bronchodilation. It combats bronchoconstriction, right? So it opens the airway. Side effects include headache, dry mouth, dizziness, palpitations, right? Every time when we say anticholinergics, we think of patients who can't pee, they can't poop, they can't see, and they can't spit, right? Because it dries up those mucous membranes, right? So it dries up the mucous membranes, but it produces vasodilation. And that is how it helps the patient with COPD. Right? So mucineric agonist, it dries up the mucus. That's how I want you to think about it. So when we refer back to the plan of what we were going to do for this patient with COPD, how do we fix the anorexia, the fatigue, and the weight loss? Well, remember the weight loss, anorexia, and fatigue is more so associated with emphysema. So what are we going to do as the nurse? Right? So we're going to follow these nutritional guidelines. You want your patient to eat high calorie foods first, right? So, for instance, if they have a plate in front of them, and let's say they have something with noodles on it, or something with some type of protein and high calorie, you want them to eat that first. So, even if they do decide they don't want to eat the rest of their food, they have something of some caloric value. You want to limit liquids at mealtime. Right? This patient will drink and become full and then not want to eat their food. That's counterproductive for them to gain their weight back. You want them to take some rest before meals so they're not tired when it's time to eat. Remember, sometimes this patient has to choose whether they want to eat or if they want to breathe. They're so dyspneic, right? They're having trouble breathing. So they need to rest, maybe oxygenate before they eat. We want to try them on more frequent meals and snacks. Maybe, let's say, like 6 meals throughout the day, small meals. Try cold foods, which make you feel less full. Sandwiches, right? Or salads with some type of protein attached to it. Keep prepared meals ready and available of time of shortness of breath, right? If they have pre-prepared meals in the refrigerator, when they are hungry, they'll have something available to them, and then they didn't have to put out a lot of exertion. All in all, if it's something that's more specific, then you need to refer this patient to a registered dietitian. These are things we educate the patient about, but we do not prescribe diets. Remember, you are a registered nurse and not a dietitian. We are referring back to the planning stage again. How do we teach the client to prevent COPD exacerbations? We want them to avoid triggers, viruses, and pollutants, right? We don't want this patient having bacterial infections such as pneumonia, right? This is one reason why we recommend the pneumonia vaccine. We don't want them getting viruses like influenza or COVID. This is why we recommend the COVID-19 vaccine and the influenza vaccine. We want them to be mindful of pollutants. Remember, we talked about those cold red days or days when the heat index or the pollution is more increased outside. All of these situations inflame a COPD airway, right? And then it contributes to exacerbation. Even high pollen in the air, right? If someone has allergies, can create inflammation in the airway. Sometimes we'll treat these patients with allergy medicine. Whatever we can do to decrease the likelihood of them going into an exacerbation, we will do. The other part is, we miss this a lot, is teaching your patient about infection control. What is one way we decrease viruses? We teach our patients to wash their hands. How else can someone get a virus? Right? Being around other sick people. Also, wearing a mask in public. So just little things that we can do to educate the patient about decreasing the likelihood of developing some type of infection or virus that can contribute to them going into an exacerbation. So what do exacerbations do? Right? They are further damaging that patient's lungs. What are you doing when your patient comes into the acute care setting with an exacerbation? Number one, you're going to manage their symptoms, manage their airway, and make sure they're being oxygenated well. You want to prevent complications such as respiratory failure and correct any acidosis that the patient might be having, and treat the underlying infection or maybe even the cause of the exacerbation. For instance, if your patient had influenza, we have to treat the influenza and the signs and symptoms of the flu to help decrease the exacerbation. Signs and symptoms of respiratory compromise and distress: altered mental status, dizziness, restlessness, right? Especially with this COPD patient that might have some type of respiratory acidosis going on. They are retaining carbon dioxide. Well, what happens when your body is in respiratory acidosis? You become confused, right? So that altered mental status is very important. Your patient comes in with a COPD exacerbation, you need to be doing those neurological assessments. This patient may also be blue in coloration, right? That's a sign and symptom of cyanosis, or that they're not being perfused properly. They might have straining of the neck and facial muscles, flaring of the nostrils, pierced lips. All of these are signs and symptoms of respiratory distress. They may have sharp or stabbing pains in the chest due to being unoxygenated or that bronchial constriction. They may have cough, crowning, or high-pitched barking sound. Again, that comes into play with that bronchial constriction and not being able to get air through that airway. Strained chest muscles and abdominal muscles, right? They're using accessory muscles. They're coughing a lot. A lot of times when people are coughing a lot or even using other muscles besides their diaphragm to breathe, they can strain muscles and become uncomfortable and have pain. When we're talking about oxygenation for a COPD exacerbation or even oxygenation for COPD patients, they have a different oxygenation level that we look to. All right. A patient with COPD, and especially late patients with COPD, they can get away with a pulse ox reading of 88. Right. So we really look to sometimes just correct the symptoms and see if they're having work of breathing problems or if the work and breathing is improving less than oxygenation. If we over-oxygenate this patient, a lot of times we can decrease their will to breathe. And we'll explain this a little bit more. Again, this patient that comes in with a respiratory acidosis secondary to end-stage COPD exacerbation. They'll appear to be cyanotic around the lips and the earlobes. They'll be tachypnic, right? Respirations will be increased, but rapid and shallow. When you take their arterial blood gas, it will have changes in the acid-base balance, right? We said that they'll have respiratory acidosis, and that's what you'll see based off of their ABGs. This is what leads to the confusion. As you can see in the picture, this patient is altered. So they'll have an altered mental status due to respiratory acidosis secondary to end-stage COPD exacerbation. End-stage COPD and oxygenation. The currently accepted oxygen saturation target of 88 to 92% is an attempt to provide adequate tissue oxygenation while avoiding complications of hyperoxic hypercapnia by giving the minimal amount of oxygen needed to stay above severe hypoxemia. What does that mean? This means that we have an exception to everything we've ever taught you about oxygenation. This end-stage COPD patient will thrive between 88 and 92% pulse ox. If we take this patient up too high, let's say we give this patient 100% oxygen, it will trick their body into thinking that they are oxygenated well, and it will decrease their breathing drive. It will decrease their will to breathe, and it will be detrimental to the patient. So we like to go off of symptoms sometimes of severe hypoxemia, and we stay at the target of 88 to 92% with end-stage COPD patients.